Our next presenter is Dr. Aasim Padela, and he's going to be talking about research-driven service. And I think it's a good culmination as we kind of wind down here about how we really need to look at our community and the communities that we serve in the lens of being able to find the proper mechanisms to find and identify problems. Dr. Padela is assistant professor of medicine at the University of Chicago. He is an emergency medicine physician, health services researcher, as well as a bioethicist whose scholarship focuses on the intersection of minority health and bioethics through the lens of healthcare experiences of American Muslim patients and healthcare providers. He's spoken internationally, locally, local to Chicago here. And I think his presentation will do a good job of summarizing, I think, our mandate as American Muslims in terms of truly understanding the patient population that we're serving and what lies ahead. And after this, it will be a culminating 2 talks about how we can kind of carry on this work. So please help me in welcoming Dr. Aasim Padela.
Assalamu alaikum. Please go ahead and get your coffee. Alhamdulillah Rabbil Alameen wal aqibatu lil muttaqeen was salatu was salam ala khayri khalqi Muhammadin wa ala alihi wa sahbihi ajma'in. Allahumma allimna bima yanfa'una wa yanfa'una bima tu'allimuna wa zidna bi fadlika ilman wa ta'liman innaka ala kulli shay'in qadir. So I'm privileged and honored to be here amongst this auspicious gathering to speak a little bit about something totally different for a moment. We've been dealing with finances. I want to talk a little bit about philosophy, so this might be a little bit of a break for you all anyway. I want to thank the organizers for putting this conference on and for allowing me to join you for a few minutes. So basically, I'm going to speak to this topic, philosophy and data, an evidence-based approach to healthcare service, or alternatively, the title here is Inspiration, Aspiration, and Perspiration, Islam and Healthcare Delivery. So to begin with, I just want to tell you a little bit about the program that I lead at the University of Chicago. It's the Initiative on Islamic Medicine, and we reside at this intersection here between the seminary and the academy along the axis of Islam. So our focus is to understand and help bridge the gap between the seminary and the academy, where the seminary thinks about Islam as lived practice, a tradition that has a lineage of 1,000-year-old, and the academy looks at it as a philosophical or theoretical framework, right? So we want to bridge this gap between theory and the lived embodiment of the faith. At the same time, the other axis that we work upon is the axis between the Muslim community and the healthcare system, where the Muslim community is a community that has needs, healthcare needs, social needs, and the healthcare system tries to provide for those, including spiritual needs. So how we bridge that gap along the axis of American Muslim health. Ideally, our focus is to bring people together, right? To have a conversation where we translate concepts that reside in different spheres of influence, hence the title of the talk, From Philosophy to Data. So here you all gathered here today, and I was just looking at some of the mission statements of the organizations that have sponsored this conference or this symposium. And to me, it appears that there is an Islamic inspiration to the work that you all do, right? From Ummah saying that healthcare for all inspired by Islam. AMHP talks about themselves as where faith and communities come together. You know, Iman has in their vision statement, they want to be the model of Muslim tradition facilitating transformational change in urban communities. And Imana, his goal is to become the recognized leader in national and global healthcare guided by Islamic values. So you see here, there's a commonality of an Islamic inspiration, a potential Muslim identity. The question for all of us is, what does Islamic look like and mean? Right? So medicine and healthcare attend to similar things. They attend to human frailty. For example, illness disturbs one's body. And it's a reminder for those who are going through that their life is finitude. There's finitude to their life. It will end. The thing that you think you control, right, is your body. You can't control your children. You can't control your environment, but you think you can control your body. But when that body starts to fail you, when that little virus puts you in bed for 3 days, you are reminded that even that thing that you think you control, you cannot control. That precious gift is at risk. Medicine responds to persons at an intimate moment of helplessness, right? When they're helpless, they don't know what to do. For many, medicine is a magical treatment. Right? We can cut out this issue, this cancer, or we can give you this medicine, therefore you'll feel better. But that's also a godly response, that you, in your needs, in your health, in your helpless state, call out to God for help and assistance, not knowing where it will come from. So medicine attends to this same need. healthcare assists people with trying to maximize their full potential, realize their full potential in this world, right? They maximize the benefit of one's life. When you're healthy, you can do things that you can't do when you're ill. Medicine helps people actualize that, right? Healthcare helps people actualize that. So in a certain sense, medicine and healthcare tend to human frailty and tend to a thing that is a spiritual crisis at times. The Islamic scriptures that we have provide a substrate for the philosophy of care within that. So again, one of the sponsoring organizations for this symposium, this is a Shifa clinic, I believe, in Houston. I visited, and they have this little thing on what they call, when I am ill, it is He who cures me. This is a verse from the Quran. وَإِذَا مَرِضْتُ فَهُوَ يَشْفِينِ. What does this say? So I want to spend a moment and help us think about this for a second. On one scale, it talks about the ontology of where disease and illness and cure come from a higher power, from God in the Muslim sense. But it also crystallizes for us as physicians or healthcare providers that we are in the service of this entity. That when we are delivering healthcare, we're acting out that embodiment, right, of providing cure. The clinic itself is called Shifa Clinic, right? And we know one of the names of God is in the Islamic tradition is Ash-Shafi'i, right? The one who cures, the one who heals. And reflecting upon that for a moment, this term, there are many different ways that this characteristic has been talked about by the scholars of the tradition. In one paradigm, they talk about they divide the attributes of God into Jamali and Jalali. Right? Jamali being those that are beautiful, awe-inspiring names of God. Jalali being those who talk about His power. Right? And the Ash-Shafi'i is classified as a Jamali characteristic that talks about His beauty. And underlying all those Jamali characteristics is the idea of rahmah, of mercy. That each one of these characteristics as embodied in the world, as He is the reality and all of us are a reflection of that reality, and our actions talk about and embody that reality, if we are acting out that embodiment of a Shafi'i, right, of the one who cures, it must be done with a sense of, or an embodiment of mercy. Now you might say this is high in the pie in the sky, 50,000 foot view, but let me give you an example of how this plays out in the lives of people. So I participated I was with some Muslims doing some health work, and in their healthcare system, I was quite astonished that what would happen would be that they would send when people were at the end of life or had just recently departed this life, at times they would be practicing procedures on these bodies because they were in the service of learning medicine. They were in the service of learning medicine. And the question became, well, these bodies are Muslim bodies, these people are Muslim people, how come they are acting like this in the service of medicine? And they had rationalized in many different ways that this is a necessity to learn. We don't want to practice on people who are patients, we want to practice on bodies. But the question for us becomes, if we are living out and embodying this idea of being merciful and practicing the characteristics of Allah, where we are giving healing to people, is this something that coheres with that practice? Or when we provide medical relief and we have people who are practicing outside of the scope of their practice, saying something is better than nothing, some care is better than no care, is that an embodiment of the idea of mercy? The philosophy plays a role in the day-to-day practice. And for many of us, we are detached. We are detached from that. But my point only here is to say that the Islamic scriptures do provide a foundation for such a philosophy. Moving on, let me give you an example of where this plays a role. So in Malaysia, the International Islamic University was given the ability, they petitioned to the government in 2009, they wanted to build an Islamic hospital. And this, I don't know if I, do I have a pointer here? No, I don't. Oh, let's not do that. So you see here, what they did was they got it together, architects, and they got it together, hospital planners, administration, and they said, we want to build a hospital, right, that is ibadah friendly. For them, they felt that the idea of what is the purpose of our life, it is, as the Quran tells us, لَعَلَّكُمْ, what is it? The purpose of our life? مَا خَلَقْتُ الْجِنَّ وَالْإِنسَ إِلَّا لِيَعْبُدُونَ, so that we worship, that you worship God. So they felt that the hospital should be conducive to worship, in whatever case it is. So while there might be in the room facilities for people to use the bathroom, that bathroom must be created in such a way that people who are sick can perform the ablution. That when they have light coming into the hospital, there should be an area where people can reflect and think about. That there should be spaces for people to reflect upon the sacred. Right? And this was the classical tradition of how Bibaristans in the Muslim world were created. So they said, we want to revive this tradition. That even in the architecture, there should be an idea of facilitating worship. Moving from that architectural planning, again in Malaysia, the concept here, I've noted this hospital, Al-Islam Hospital, they call themselves the worship-friendly hospital. And for them, they said, again, here, our idea here is that illness challenges people's ability to worship. And what we are going to do is facilitate that worship. So on the intake, the nurses take, they say, okay, do you want to be woken for prayer? Do you need help performing the ablution? Can you not have used water? Can we provide for you some sand for tayammum? Do you need understanding of how should you pray or not fast during this illness? We will provide for you that religious guidance, not only through booklets, but through consultation with shuyukh who can give you that guidance. Right? And you see here, they said each employee, I can't read that from here, but each employee regards the daily chores and duties assigned and carried out as a form of ibadah. For them, they would bring together the entire hospital staff and they would have halaqat, that they learn about what they're doing and servicing the people. That they're acting out an attribute of God's mercy. So the philosophy had an implication upon the day-to-day practice of a hospital. And for them, this was an idea that came from their tradition. I'm not saying it is the only idea, but you see here how it played a role in what they did on a day-to-day basis. So let me speak now to the American context a little bit, and I want to thank Rashid and others from Imana for helping me conduct this national survey of Muslim physicians through the Imana membership. We conducted a randomized 10% sample of the Muslim physician group, in that, Muslim physician amongst that membership group, and here is some data from that I want to share with you. It's not public yet, but you guys get a preview. So 81% of those physicians had said that they agreed with the statement, I feel called by Allah to practice medicine. But we had many items talking about Muslim service. And I want you just to note for a moment what that meant to them or did not mean to them. When we asked them if they provided medical relief work, you see 74% said never, and 26% only a few times a year or less. We asked them, do you serve? And does that mean to you when you're called by Allah to serve in Muslim clinics? You see 58% said never. 32% said a few times or less a year. When we asked, well, does that mean to you, you're going to assist imams with the bioethics cases since you are the medical experts? You see here more than 2/3 said never. And a very few said a few times a year or less. If you think about providing consultation to Muslims in the mosque, as the doctor amongst the community, again you see here a bit better than the others, but a third said never, and a near half that's a few times a year. So the idea of servicing our community was not very much present in this group for a moment, right? That there was a philosophy that yes, we are called to practice medicine by God, but how do we implement that? There was a gap. If you think about, for me, this is my shtick, academically Islamic bioethics. So you see here again, you see a gap that, and I didn't present the first data point, but let me present you the first data point. Nearly 80% felt that Islamic values, Islamic bioethics influenced their medical practice. When we ask them, how do you figure out what Islamic bioethics says, you see the data here. That, do we read Islamic bioethics books? 55% never or rarely. Do we talk to Islamic jurists? 64% never or rarely. Do you read these academy verdicts that are with physicians and with scholars coming together deliberating over the pressing issues of today? Almost 80% said never or rarely. So again, a gap between a philosophy, I'm called to practice medicine, or I practice medicine according to Islamic values, but on the ground level there was a missing idea of what that is. What does that look like? I wanted to call your attention. The John Templeton Foundation did provide the funding for the study, so I want you to know that this study was conducted from was conducted by the funding from a source outside of our community. It wasn't even our own community that was deciding how do we think about this. It was an external funder that was interested in what Muslims do and how they live out their practice of medicine. So AMHP talks about this, and so Arshia, this is a great slide from your, I think it was on YouTube. This is one of the things you inspired people to think about healthcare reform. So we talk about American Muslim health professionals, and you see the language here. If you're watching this, that you're most likely a health professional or an aspiring health professional. So we talked about inspiration and aspiration. And the next statement says, someone who has a duty towards their community members. And the data I just presented to you, there's a gap between an aspiration or inspiration and a service modality. Right? Is there a duty? Is there a perceptive duty from an Islamic tradition for this group of people? So what are the implications for this? The implications are really for us to think about as we come together with Muslim clinics here, American Muslim Health Conference, what is an Islamic vision of healthcare? And how do we live that out? How do we live that out? Is it just a line in our vision statement? Is it just an aspiration that we think about but has no practical modality for us? Is there anything distinguishing us from others when we provide health care? I want to spend a moment from the patient perspective for a second. So we talked about Islam, and there's a gap here of Islam motivating Muslim physician behaviors, but I'll give you a study that we did, that we participated in my center. We looked at ACA reform, and we found that religious motivations, religious attitudes, had no association with eventual support for ACA. No association with eventual support for ACA. So while we talk about, and there was a lot of, let's come together as faith communities to support ACA, there was a lot of talk about, let's, as Muslims, have a duty to think about providing for others through social justice mechanisms. You should know data provides that nothing. That was of no benefit. There was no association. You came in with an idea about what ACA was for or is not for, and you voted along those lines. You supported it that way. No association on a public polling. So again, the gap here is we want to use Islam as a motivatory force, but how do we do that? And do we truly do that? How much time do I have, Adil? You wanted me to cut short. Where is he? Oh, all right, good. So, all right. So I was going to stop here because he told me, we were running behind. But let me go on for a second. So the implication here, so again, from aspiration, inspiration, now I want to take you to perspiration. All right? So perspiration for a moment. So we are here together as people who are practicing in the health delivery mechanisms of the United States. And for many of us, we think about healthcare as an ultimate good. This is a press release from a JAMA study that came out last year. And really, we knew this, but this is really hard data to swallow. More healthcare isn't always better healthcare. So they did studies, there are multiple studies, but they looked at a meta-analysis of studies looking at patient perspectives and physician perspectives around the benefit of just various types of preventive healthcare. Screening, for example, vaccination, for example. And they found that both physicians and patients overrepresented and overthought about the benefits of something. When they counseled patients, they over-counseled. This is much more beneficial than it really is, right? But we know that more healthcare does not mean better healthcare. You can be a high utilization. For example, I work in the emergency department. I can tell you there are patients who come all the time, every other day, every week. But because they're utilizing healthcare services does not mean that they're getting a better health out of that utilization. And we have an internal bias to think that way, right? We have an internal bias to think that way. Yet when we deliver healthcare to patients, we need to be very cognizant that we are doing it in an ethical manner, that we tell them the benefits or not. So let me give you an example, not from from the United States, but from data all around the world. And I work on breast cancer and mammography screening in the Muslim community. So we know from data from many countries that the ideal status of a nation that does not have mammography screening is to move that population level metric to around 70 to 75%. Maybe in some countries, 80%. But it's country specific. Because over that period, you will not get the benefit of mammography screening. Why? Because you'll have a lot of false positives. You'll have people thinking they have cancer, they don't have cancer. They'll have many tests to prove that there is cancer or not cancer. Some people will have surgical operations that are unnecessary. So they don't say get to 100%, get to 99%, 95%, get to 70%, get to 80%. Because at some point, healthcare is more risky than beneficial. And for us to think about that is very important as we deliver healthcare to people who have not had it. We might move them up, but there are some people who are chronically utilizing healthcare, right? But there is a risk-benefit ratio. And for us to think about that, it's perspiring. We have to sweat. I'm a physician. I sweat about that. We know that, again, here this is about Muslim clinics. Well, we know from many data here that medical care in the health of a population, they say that 10% of health, right, or early deaths are attributed to medical care, meaning preventing early deaths. Medical care. You see all the other boxes here? So as a group of people who are delivering healthcare services, who are worried about the health of our communities, be they Muslim or not, are we interacting with the other sectors here? Are we helping people live better lives by thinking about you shouldn't start smoking, you shouldn't start drinking? Or are we worried about the after effects of that? Right? Are we delivering talks about, well, not our community, Muslim community, there's not much data on this yet, But there are a lot of it. You'll see in Saudi Arabia, in Qatar, they're starting these biobanks and look at genetic risk profiles for personalized medicine for Muslim communities. They're mostly Muslim. How do we think about that? How do we mediate genetic risk factors in our community? Do we deal with the social circumstances of people? Right? In the emergency department, again, this is very clear. I can prescribe medicine to people. I just had this on shift 2 days ago. I wanted to give someone Lovenox for a PE. Right? I didn't want them to stay in the hospital for 2 days because that would cost a lot of money. So I wanted to give them Lovenox. You know what the copay was? $5,000. That was the copay. So I had to admit him to the hospital for 2 days so he can get Lovenox, because if I can send him home, he will not be able to get that Lovenox. So how do we think about those social circumstances of our patients that we take care of? And is there an Islamic vision for that? Is there a Muslim inspiration for that? So I want to point towards a little bit about the Muslim community. I know that most Muslim clinics, aside from the ones that are in mosques, do not service predominantly Muslim populations. We know this, and nor should they. But our research shop did a literature review of Muslim healthcare disparities over a 60-year period. What was documented over the 60-year period? So you just have the byline, it just came out. And I'll tell you that of the 3,000 so studies that we looked at, of which 171 were kind of comparing disparity studies, they were looking at different rates and statistics, of them only 20 mentioned anything about Islam being a factor in healthcare behaviors. 20. So while these were population studies of Muslim groups, only 20 of them thought about Islam having any impact upon their daily life and thinking about healthcare behaviors. That's a problem. If we come together at American Muslim Health Conference, the first 2 words, American Muslim, there's something uniting you, right? All your vision statements, something unites you. But when we look at patients, we're saying, oh, we're not going to look at their Muslim factor. We're not going to think about how that plays a role. I think that's a problem. For faith communities to think about delivering healthcare in our faith communities and leveraging faith for health, and we miss the idea we have to study this, we don't look at it, that's a problem. And then we can never go to what this next banner here is research-tested intervention programs. I told you that I work on breast cancer screening, right? The NCI has all of these research-tested intervention programs. Whether you look at a specific community, be it a Latino community or Mexican community, or you might not look at it as an ethnic community, you might look at Southside Chicago. And you say, what are the problems for people getting XYZ? Say breast cancer screening. You do surveys and you do qualitative interviews to think about what are the particular barriers here in this geographic or this ethnic community. And once you survey that, then you think, okay, well now I'm going to create a program that's evidence-based to address those specific things. Not something from somewhere else, but specific to this community, what are the problems here? Is it that they don't have transportation? Then we'll work on an intervention that helps with transportation. Is it that they don't know about the benefits of screening? Then we'll work on an educational program. It takes a cycle of 10 years of research to go from thinking about what are the problems here to developing a program that can be beneficial here, potentially. You test it, you evaluate it, and then you want to say, I want to generalize it. For our community, there are zero programs on this about Muslim communities. And I think, again, that's a problem for us who are servicing and working in the Muslim community. 5% of the physician workforce in the United States is from a Muslim majority nation or identifies as Muslim. 5%. That's huge. Yet for our community, there's very little data out there. And this is the sort of work this is what I think is an aspiration that we should have, but will require a lot of perspiration and effort and work. So in the end, why? Well, knowledge is what empowers you, right? We can't say, oh, I tried this and I'm done. I looked at that and I'm done. But how can other people benefit? Through dissemination activities where you publish your work, you're critiqued and evaluated, right? Then you can say, oh, this worked. And we have a lot of projects and programs that occur in our community around health that don't get to that cycle of publishing and producing. So other people can benefit, nor to get critiqued a bit to improve the work that you're doing. And I encourage us all to think about that. So in the end, I'm going to end with this story. I think I mentioned 20 minutes. I'm there, right? Yeah, I'm good? Yeah, okay. So let me tell you this story. So yes, at the Initiative of Islamic Medicine, in this June, we're going to have a workshop on the ethics of organ donation. But I want to tell you how this started. Just for a moment, thinking about how you come to, why do I want to do this educational intervention? So in 2009, I was at the University of Michigan, and there was a survey done of the Arabs, a Detroit area Arab study. That's what's called DAS. Within which there were, in Michigan, you have a lot of Arabs, about 50% are Muslim, 50 are not. So one of the outcomes in that study, we published on this, was organ donation attitudes. Right? So they asked people, do you believe it's ethically justifiable to donate your organs after death? We found, from looking at that data, that being Muslim was a predictor of having a negative attitude towards that. Just being Muslim, compared to Christian Arabs. You could isolate that from, we controlled for social demographic status, for health insurance, for age, for whatever else you can think about in that survey. But just being Muslim. So the question was, and people asked, well, why are Muslims not inclined to think about organ donation? So that study I had conducted, then a student of mine at that time was an undergrad, said, well, I want to look into this. So we did a literature review of all studies that were published on Muslim populations locally in the United States and abroad, thinking about what we know about how Islam influences their beliefs around organ donation. And we found surveys that were done that again said that Muslims, those who are highly religious, are less likely to pursue organ donation. We found that there were interventions done, that people had said, okay, well, what we need to do is get a religious leader to say it's okay, so that issued fatwas. This was a Birmingham study, right? There were some in Turkey as well, where we're not going to just issue fatwas, we're going to have an educational seminar in the mosque where we get people who are highly religious to come and tell them that there are religious rulings that say it's permissible to donate your organs. And then they evaluated them, and what do they find? No change in behavior. No change in behavior. And my student and I said, well, why is that so? Because they thought that, well, religion is a problem, right? Or religiosity is a problem. Get highly religious people to issue fatwas and then give educational seminars, and there you go. So in our understanding, this is the philosophy comes in, that it wasn't that they felt that a religious ruling didn't exist to permit organ donation, but the integral aspects of organ donation they had confusion about, or they were worried about, right? And that the modality of delivering that information was a fatwa on a piece of paper. But how many of us are going to be influenced by a fatwa from someone we don't know abroad, whoever he is? It was never delivered at this minbar, at the sermon level. And the translation from the juridical ruling, which said there is permissibility and impermissibility, two plural camps. One says impermissible, one says permissible, never made it to the minbar where they were delivering this information. And the programs, and people picked up that the programs were just talking about permissibility, not impermissibility, and thinking about the two sides of the equation. Which one do you want to be motivated by? The Muslim community was not unknowing that there were fatwas out there. So in the end, so in the UK, this is a group that I was collaborating with, and here we said, well, you know what, we need to have an educational intervention. And not one that just says promote, but makes informed choice. We talk about the various rulings that exist. We talk about the data that exists from Muslim communities. We talk about the interventions that failed or succeeded in the Muslim communities. And we talk about the lived experience of patients in Iran where they have an organ market, quote unquote, right? In Saudi Arabia where they don't, where they do a lot of transplantation, but they don't have to have an organ market. There's a lot of donation. They don't think they're running out of organs. To help us think about in the United States, what do we do for our community? That was from 2009, we're at 2015. 6 years of work to think about an educational intervention. So I'm calling upon you to think about not just the inspiration and the platitudes of Islam, but to do that work at the ground level will require a lot of work, a lot of attention to detail, a lot of research, both theological research and health services research. And I call upon us to think about that as we move forward. Thank you.